about autoimmune liver disease at this last few days, so I'm going to talk about what's different in children. And some of the big questions are, is it the same disease? Are we just looking at the childhood onset of an adult disease? Or is it a completely different disease? And the important thing that I want to say is with children it isn't always that clear, and I think our long-term implications are very different. So I'm going to talk a bit about autoimmune hepatitis, sclerosing cholangitis, and I also want to talk about de novo autoimmune hepatitis, which occurs after liver transplantation. So if you look at the spectrum of disease in children, we will have all of the clinical entities that you have heard about in the last 2 days, but we do have a great deal of overlap. This is overlap syndrome, in which there is a mixture between biliary damage and a hepatitis. And that, I think, is more common in children than in adults. It clearly happens in adults, but I think we see more of it. And of course, there's the association with inflammatory bowel disease. Now, children, unlike adults, having a chronic liver disease has significant effects on their growth, their psychological development, their physical development, and of course their education, because if they cannot attend school, it affects their education. And then we have the whole marvelous time of adolescence and teenagers, and then transition to adult care, which has big implications for adherence. And unlike your adult patients, they are going to be on immunosuppression for most of their lives, and that is a really important difference. How common is it? These are 2 studies that looked at how common autoimmune hepatitis is more common than sclerosing cholangitis or autoimmune sclerosing cholangitis, and more common than sclerosing cholangitis in children. And as you can see, it's less common than in adults. Recently, the prevalence in Europe is about 15 to 25 per 100,000 in Europe. There are more females than males, particularly after puberty. Before puberty, the sex ratio is quite similar, and the incidence appears to be increasing, and whether that's because we're getting better at diagnosing it or whether it's more common, I think, is not clear. 20% have other autoimmune liver diseases, and there's 40% family history. So for pediatricians, the important diagnostic investigations are not just to make the diagnosis of autoimmune liver disease, but to exclude other liver diseases that are very similar. And Wilson's disease is the one that is most difficult to differentiate, because it can also have non-specific autoantibodies, and it can also have a rise in immune globulins. So it's very important that the diagnosis is made. I think also in children, the association of autoimmune thyroiditis and celiac disease are often secret and silent. And if a child doesn't respond to immunosuppression, one of the things that I often think about is, do they have another autoimmune disease that we haven't picked up and that we're not diagnosing? We also, as baseline for all forms of autoimmune hepatitis, look for sclerosing cholangitis and look for inflammatory bowel disease. And we do this using fecal calprotectin, which is quite a nice marker. If it's positive, we then go on to do a colonoscopy. And we look for evidence of celiac disease in every child. And now standard, I don't know whether you can see it or not, is that we also do an MRCP for sclerosing cholangitis. And the reason why will become obvious as I explain in my talk. So the autoimmune hepatitis is very similar to adults, can present with acute, chronic or fulminant hepatitis. I'm sure you've heard already throughout this meeting of the positive non-specific autoantibodies, and in general there's quite a good response to treatment, 80 to 90%. Type 3, which is a newer form of liver cytosol antibodies, is very similar in clinical phenotype to autoimmune, but a little bit more severe. Type 2 autoimmune hepatitis, again, I'm sure you've had discussion about that throughout this meeting. In our practice, in pediatric practice, it tends to present more with fulminant and acute hepatitis, and it is associated with liver-kidney antibodies. In the early days of hepatitis C, when we didn't have really good tests for RNA, there was often a confusion between LKM positive antibodies and hepatitis C antibodies, and there was some confusion about that. That confusion does not occur quite so much anymore, but there is a second form of autoimmune LKM2 in which you can find antibodies to hepatitis C and also antibodies to drugs, particularly anti-epileptic drugs. And I think the important aspect about this type of LKM positive is that you may be able to stop medication once you've withdrawn the drug that stimulated the hepatitis. So you heard in the first talk about scoring systems, and Professor Ludmilla doesn't care for scoring systems. I don't care for scoring systems either. I think they're quite useful for research studies and for looking at prognostic indications. This is the International Autoimmune Hepatitis Simplified Scoring System, not specific for children, and so we have developed a pediatric one, which you can't see very well, but it is quite useful again in difficult cases to see, are you actually dealing with an autoimmune hepatitis, are you dealing with a sclerosing cholangitis? And I think again, for evaluation of new drugs, this is very helpful. Differential diagnosis, I've talked about Wilson's disease, how important it is because the treatment is so very different, but it is obviously important to exclude other forms of viral hepatitis, and particularly, and I think pediatricians are very bad at this, excluding drug-induced liver disease. I think we rarely think about it because it's so much more common in adults, but it's important to exclude that as well. Now, treatment, we're going to come on to the difficult cases in a moment. Treatment is really no different to adult therapy with induction with prednisolone, and I don't use 60 milligrams a day as my maximum. My maximum is 40 milligrams. I think 60 milligrams is too high, but in the textbook 60 milligrams is still quoted. And when the transaminases, the biochemical response is clear, to add azathioprine for maintenance. I like to use steroids on alternate days. Not all my colleagues do that, but I think it does help growth. So what are the difficulties with treatment? I've already said these children are going to be on this treatment for life, and so they have very severe side effects with growth, with stunting, and with teenage girls, it is really, the use of steroids puts on a lot of weight. They get very overweight and they don't like these cosmetic effects. They don't take it, that leads to relapse, that's very difficult. And then, of course, they've got all the long-term risks of immunosuppression, infection, and malignancy in the long term. And I think we must remember that if they've been on immunosuppression for a long time. So, Professor Ludmilla, what do I do if they are difficult to treat? And I think if they do not respond to prednisolone and azathioprine, I look to see have I got the diagnosis right. I look to see have they got sclerosing cholangitis, not just straightforward autoimmune hepatitis. And my second-line treatment is either cyclosporin or tacrolimus or mycophenolate. And of the three, cyclosporin is the most effective, but nobody wants to take cyclosporin because of the cosmetic effects. So usually tacrolimus is my first choice if they have difficulties, plus or minus mycophenolate. I have had no experience of using cyclophosphamide or rituximab. There are isolated cases of so doing in the literature, and there's very recently been a trial of budesonide and azathioprine in both adults and children, and really the children did not do very well on budesonide. They didn't do as well as adults, and most children don't have cirrhosis. The other big difficulty is when should you stop immunosuppression? And parents always ask you this, and the children always ask you this because they don't want to take the medication. And again, if we go back to the textbooks and guidelines, if there's been biochemical remission for 2 years, the liver biopsy is normal, then you can try it. But in my experience, they all relapse. So I do never stop immunosuppression. I bring it down to the lowest maintenance that keeps them well, and I never stop it. And in fact, in adults, as you probably know, there's much higher problems with relapse. And my experience is once you've had a relapse, it's very difficult to get remission. So I believe you do relapse at some stage. It may take up to a year. And of course, children will withdraw themselves. They'll stop taking the medication. And I find that it's much more difficult to get them back into control. I always do a liver biopsy because I think with children you can't take the risk that you're missing something, that you're missing a super infection, or they're taking some other drugs on afterwards. So I always insist on them staying on medication. I'm just going to move on to talk about sclerosing cholangitis, and there is controversy about whether sclerosing cholangitis is autoimmune and a separate disease to what was described in adults as primary sclerosing cholangitis. And my personal view is that autoimmune liver disease is a spectrum, that you've got hepatitis predominantly with hepatocellular damage and sclerosing cholangitis with predominantly biliary damage, but that there's a big spectrum in between. And that's based on some more data I'm going to show you. But again, sclerosing cholangitis doesn't present very differently in children to adults, with hepatitis and jaundice, and of course a higher association with inflammatory bowel disease. We now have such excellent imaging that you can make the diagnosis very easily on MRI. You get these lovely pictures, and this is the real clue that the child has sclerosing cholangitis. The gallbladder is nearly always very enlarged in sclerosing cholangitis. That's a very important practical point. And the histology, once you see it, is very classic with the sclerotic bile ducts. So my colleagues from King's published many years ago a comparison between autoimmune hepatitis and autoimmune sclerosing cholangitis. And at the time they published it, they said there were just as many opportunities for positive non-specific autoantibodies in autoimmune hepatitis and in autoimmune sclerosing cholangitis. Now I think it's because they are the same disease. I think we're just looking at the same disease with more of a biliary onset and more of a hepatitis onset. So I don't think that they are separate diseases. I think it is a spectrum. However, as you've heard the previous speaker say, there's no very good treatment for sclerosing cholangitis, and apart from supportive therapy and early consideration for transplantation. And I think this is very important. I think once these children start to do badly, don't delay the transplantation. It's really important. So I want to just touch on quality of life, because for many of these children, they will never be ill enough to require transplantation, but yet they have a chronic liver disease which affects them. And it's actually not very easy to measure quality of life in either adults or children, but in children there's also their parents' perception as well as their own perception. And it isn't always easy to get the right type of tool that looks at quality of life. And this is the one that most people use, PEDS QL. And the reason we do this is that it's a very quick to administer test. It's got opportunities for a child report and a parent report, and it looks at a variety of important functions that are important to growing children. And there's been one study published so far. I hope you can see this. Is not very easy to see. This is from Turkey, in fact, and they're looking at children with autoimmune liver disease and healthy controls. But I just want you to see their physical functioning, emotional functioning and school functioning were all very much reduced compared to healthy controls. And if the children complained of fatigue or inflammatory bowel disease as well, their scores were very low indeed. And I think this is something that we have to take into consideration in the long-term management of these children, and also whether or not they require liver transplantation. And this is just a summary of all the quality of life assessments that have been done in children with chronic diseases as well as liver disease. This is post-liver transplant, obesity, if you consider obesity a disease, but you can see autoimmune liver disease is really down here with low scores for quality of life. So I think we need to remember that. So I'm going to move on now to talk about transplantation. You heard, some of you, from Professor O'Grady about transplantation in adults. And the indications are quite clear in some cases with end-stage liver disease or acute liver failure. But if they become resistant to immunosuppression, and I would like to support his comments, please don't wait till you've tried every drug in the book and their bones have gone, they've got diabetes and they're moon-shaped. Bring them in sooner rather than later. And we've talked about severe side effects, we've talked about quality of life. The one area that I think people do struggle with is liver transplantation for acute liver failure, for fulminant liver failure, and there's a great desire to try and treat it with steroids and prevent a liver transplant. And sometimes that can work, but it is, in my experience, giving them steroids often precipitates encephalopathy, and I've had some children become psychotic with the steroids and encephalopathy, and that can be very difficult to manage. So I think it's worth giving them a trial of steroids, but really not persisting, and probably only when they're listed for liver transplantation. What should you do after liver transplantation? Perhaps Professor O'Grady talked about this. I think these are the one group of children that you cannot stop steroids. They can't go in for the current fashion of having steroid-free protocols, and they can't go in for steroid withdrawal, which some units do. These are children whose disease will come back if they don't have steroids. So we use, in our unit, we use tacrolimus and steroids, and sometimes MMF. We use IL-2 antibodies for induction, and we continue steroids always. Of course, these children have problems. They have reduced wound healing because they've been on immunosuppression beforehand. And curiously, they have increased episodes of rejection. And I think that's because their immune system is primed, because it's already primed against some of the liver proteins, and then it's primed to reject the liver. So they have a much higher incidence of rejection than other children. And of course they have infection. But the one good thing about this group of children is, in contrast to many of the babies that we transplant, they have quite a low incidence of post-transplant lymphoproliferative disease. And this may be that they're already teenagers at the time they're being transplanted, and they're already EBV positive. But that's quite important. This is the one important difference. And these are data from my unit in the days when we did use steroid withdrawal, and we learned the hard way. This was not the way to do it. So this is looking at chronic hepatitis-free survival, and this is our normal population, and they do develop chronic hepatitis. We've documented that, but the ones who had autoimmune liver disease had significant development of autoimmune hepatitis, and of course they were getting recurrent disease, and that's one of the reasons why we don't discontinue steroids. So about 25% of them will get the disease back. So transplantation is not a cure. Very important that that's explained to the family. But they do respond to steroids and azathioprine. But if they don't respond, they're going down the road for a second transplant. So it's quite important to try and prevent the recurrence if you can. The same is true with sclerosing cholangitis. The recurrence is about 16% or so in children with PSC. This is an American study which looked at children with PSC, and about 6 to 14% of them had recurrent disease. What is a little bit different is that the diagnosis of recurrent disease with sclerosing cholangitis is much harder because it's a biliary disease, and then you're not sure, are you looking at chronic rejection, are you looking at cholangitis, are you looking at ischemia with biliary damage. So this is a difficult diagnosis to make, and it's dependent on both histology and radiology. So I'm going to touch now on de novo autoimmune hepatitis, which is a disease in which autoimmune hepatitis occurs in both children and adults who did not have autoimmune liver disease in the first place. And it presents exactly the same as autoimmune hepatitis, with graft dysfunction, high immunoglobulins, autoantibodies, and responds very well to steroids and azathioprine. It's not quite clear what it is. Is it a molecular mimicry, or is it a form of rejection? And my personal feeling is that it is less common now that we have better immunosuppressive drugs. This looks at the scoring, the different positive scores between recurrent autoimmune hepatitis and de novo hepatitis. You probably can't see those, but they are all in an ESPGHAN position paper, which will very shortly be published. Now, I followed up with, as part of an international multi-center study, a number of children with de novo autoimmune hepatitis, and you can see it's not all that common. There's almost 2,000 transplant patients, and only 31 of them developed de novo autoimmune hepatitis, and of these, the majority responded to standard immunosuppression, but 4 of them went on to cirrhosis and portal hypertension, and 2 of them needed to be retransplanted. So not a very common disease, and one that is usually easily treated. Finally, I want to show you some data from Birmingham about how our children progressed. And this is joint work with Gideon, whom you heard speak earlier. So this is looking at what happens to the children when they move into adult services. And so, for brevity, there are just 3 groups. Those with sclerosing cholangitis, those with overlap, not quite clear which it was, and those with autoimmune hepatitis. And what we found was really interesting, that if they had a PSC phenotype, they continued to have a phenotype, but if they had an overlap phenotype, the majority of them, when they got to adult life, had developed sclerosing cholangitis. And this was not so for the autoimmune hepatitis. So we're looking here at the autoimmune hepatitis. You can see that they stay pretty well like autoimmune hepatitis across the time, whereas the overlap children have mostly moved in to having sclerosing cholangitis. And unfortunately, and that's worse if they have the onset of inflammatory bowel disease too, because those with true autoimmune hepatitis develop no inflammatory bowel disease, whereas those with sclerosing cholangitis and overlap both ended up with inflammatory bowel disease by the time they got to adult life. And their overall transplant-free survival was much less if they had overlap or primary sclerosing cholangitis. So they're very difficult diseases, and that's why I've said to you, I think it's really important that you have a low threshold to transplantation for sclerosing cholangitis. So by 10 years of follow-up with these children, 30% of the autoimmune hepatitis had been transplanted in adult life, about a third of sclerosing cholangitis, and 20% of PSC. So when you're counselling with families, they've got about a 30%, 20 to 30% chance of needing a transplant in adult life. So what's next? I just want to tell you a bit about the rare liver, which is part of the new European reference networks. This is a network across Europe for both pediatric and adult liver diseases. It's very much sponsored by EASL from the adult side and ESPGHAN from the pediatric side. And the purpose of these reference networks is really the implementation of guidelines, the development of outcome measures, all designed to improve the standard of care across Europe. There are 3 main pillars in the rare liver disease, and there's an autoimmune pillar, which Ansgar Losa leads from the adult side, and I lead from the pediatric side. There's a group on biliary atresia and metabolic diseases, and then there's one on structural liver diseases. And I think that one of the very important things that we have done is to set what we believe are the outcome measures for ideal management of pediatric and adult autoimmune liver disease. And I put in here some of the parameters: biochemical remission in 75%, the need for second-line treatment, for children, nutrition, development of puberty and school attendance, very important, and then the incidence of cirrhosis and liver transplantation. And we hope that by developing these guidelines in association with other European countries, and indeed Bulgaria can join at some stage, because I believe you haven't joined yet, but there's no reason why you shouldn't. We can improve outcomes for both children and adults with liver disease. So dear friends, a fascinating disease. The immunological basis not completely understood. Medical treatment successful in about 80%. Don't forget to refer early for transplantation, but it's not a cure. And let's hope that by working together, we can improve outcomes for all our patients. Thank you very much.